Good afternoon. If you're just joining us, you'll notice that we are just about to get underway with this Chamber of Commerce web chat. I'm Murray Norton. I'm the Chief Executive of the Chamber of Commerce. And today we're going to be talking about the progress of vaccination. Where are we and where are we heading with the vaccination programme that the Government of Jersey is currently rolling out. I can see participants starting to join us, and as they do, we'll give a little bit of time just to make sure that everyone can join. And then we'll build it from there with some Q&As as well. And whilst I'm talking about Q&As, there is a box at the bottom of your screen that says Q&A, and you will have the opportunity to add your questions to that box at the bottom. So Q&A is the Q&A, and there will be a YouTube version of this, which we will be putting out and providing the link for everyone, and for those that have missed it at a later stage. So that's where we are at the moment. I will get around to introducing some of our panelists that we have here today. No questions in so far, but we will have various questions coming our way. So if you've just joined, thank you very much indeed for doing so. It's good to have you with us here on this web chat. Right, let's get underway and introduce those that we have joining us. In fact, on one screen we have two people joining us. We have not only the operation leads for vaccinations and also the head of COVID-19 vaccination programme, that's Ross Barnes, and also Becky, Sherrington, who are a metre apart, and it's good to see them both sharing the screen. Thank you very much for being there. We've also got the Medical Director for Primary Care, that's Dr. Adrian Noon. Adrian, thank you for joining us as well. It's good to have you all with us today. Now, we wanted to check on the presentations so far. I believe we have Sarah White joining us for some unknown reason, but we'll live with that for the moment, and we'll come back in a second. We'll come back to that in just a second. We have some progress to measure on where we are on the vaccination programme so far, and we'll try and get to that in just a couple of minutes' time. First of all, Becky, the vaccination programme, people have been talking about Jersey being ahead of the curve in terms of vaccination. Before we look at the figures and before we understand where we are, what's your general take on where Jersey is at the moment? I know you're joining us from Fort Regent, which is where the main part of the vaccination has been taking place.
Well, without sounding incredibly biased, I think we're in a very, very strong position. And I can back that up by the data. So when you look at the One World org data, which compares the countries internationally, we are within the top 10. So we're doing incredibly well in terms of international standing. We've been in a very strong position from the beginning. We were very prepared. We had operational plans ready, which was stood up at very short notice, but we understood the message from the Department of Health that we needed to be operationally ready right from the go. So we worked hard to make sure we had an operational plan to stand that up and to deliver it as a mass vaccine programme. And so we were able to do that very quickly on. So the statistics are very powerful and shows where we are internationally, and we're very proud of that. And that has been a very good public health measure to put in place. Vaccinations are only one part of that programme against COVID, but we are very strong, in a very good position, which places us not only but in a public health position, but it's a good economic news story too.
Yes, and obviously with this being for the members of Jersey's Chamber of Commerce, we're a business representative organisation. It's quite clear that we need to know what's going on with our economy, and this is one of those reflections. Dr. Adrian Noon, good to have you with us as well. We've had in the past questions that have raised up the subject of the validity and the how can I put it, the effectiveness of vaccination, and I just wondered if I can just touch on that for a moment. There is a group of people who are entitled to their opinion about vaccinations, who don't feel that vaccinations are either safe or tested or are in any way effective. I mean, just so I can get that out of the way, is there a medical view on that you can give us that backs up why we have a vaccination program?
Yeah, thanks, Murray. I think historically vaccines have been sometimes controversial in some people's eyes, but from the medical point of view, it's the #1 way to eradicate disease. And we've seen that in several examples. I guess smallpox being the best example, which was eradicated with the last case in 1981. And a significant impact in meningitis, chickenpox, mumps, measles, rubella, which has given us a generation that's never actually seen those diseases. I remember when I was at medical school back in 1980s that we saw children still coming in with mumps and measles, and it was tragic. So vaccinations are the key way to eradicate most diseases, and is the #1 way to do it. And I think the other point that we just need to make is that we have worked incredibly hard here to get our vaccination program in place. But we've also been very fortunate in that the population of Jersey have almost entirely followed advice and guidance, and have done what we call the non-pharmacological interventions, the MPIs, the mask wearing, the social distancing. And the reason that that's been so important is that we're actually vaccinating a population that haven't got a lot of the disease in it. And that makes a massive difference to our vaccine program, both in terms of having people to operationally deliver it, but also being able to vaccinate people who are fit and well and healthy and can have that vaccine. So it's multifactorial, but that's why we've got to where we are in terms of our vaccination program. So it was really just to say thank you to everybody. We have all worked hard on this together, and people have, heeded the advice and the guidance, and that enabled us to get the vaccine program up and running very quickly.
Excellent. We'll come back with obviously more questions in a little while. But before we do that, Ross, you've been the operational lead for this. You're speaking from Fort Region. The logistics of getting several tens of thousands, if not 100,000 people vaccinated is a massive project. But in terms of the logistics and the operations of all of that, you're relying on an army of people as well.
Yeah, absolutely. We're not naive to the fact that this has never been done before, and it's a unique challenge, and we've had to really learn as we go. I'm working with colleagues in other nations, keeping in touch with Guernsey and the UK to get best practice and that sort of thing, and trying to implement that within the Jersey context. So yeah, definitely a unique challenge, and something we've had to adapt and learn lessons continuously since we started. But as you touched on there, the thing that's really made all this work for us has been the people. We've been incredibly blessed with the team that we've got, and they really, every day when I come into work, I've always got a smile, and I'm inspired by the people that we have working for us, because everyone from the marshals, the administrators, the vaccinators themselves, our various management staff, the St John's volunteers, our healthcare assistants, they approach every day with a smile on their face. They're ready to go, and they're really motivated to be able to make this program work, and it simply couldn't have happened without that. So definitely my thanks to the team for all their incredible work over the last few months.
Okay, thanks very much indeed for painting that picture, if you like. I'm going to share the screen so that you can take us through Becky, Ross and Adrian as well, as you see fit. But Becky and Ross to begin with, the vaccination update, where we are and what those figures look like. You alluded to them earlier, Becky, but I think it's important that we share those. So hopefully we'll see what we get up on our screens in just a second. What are you seeing at the moment? That's what I need.
Plain panel.
A plain panel. Excellent. That's good. So nothing is sharing at the moment, which is I'll let me just see. I can share this. We'll come back to that in just a second and tiptoe our way through it. But I'm hoping that I'll be able to show that to everybody in just a few seconds. Let me just reduce a few screens. I have got, you might know, about 16 screens that are open at the moment of various questions. So let's see if we can get that to work at this point. And there we have it. Now you should be able to see that screen. Are we on the right screen? Excellent.
We're on the right screen.
That's good news. I shall see if I can go to the next. There we go. Have you seen the next screen now?
Thank you. Yeah, we can. Thank you. So I promise not to bore you with 100 slides, but it was just to kind of frame the story so far, and to give you an update, that insider view really. So it started really in, just to give a context to this whole programme, we were given the alert that vaccines would be part of the public health campaign, and really that only began in September, and there was a lot of dismissive views that vaccines wouldn't play a part, it was far too early and we wouldn't be in a position. But it was really clear that we needed to be ready by November to be deployment ready. So that only gave us a very short period of time to put the business case in, to find a location, get staff in, and to get all the digital plans, comms plans, etc. in place in a 3-month period, which is a big task for something that's a small government when you compare to the Crown dependencies and other UK nations. So we did that, and we were ready, and we started vaccinating on a very cold, wet December morning, which began a day early in the nursing and residential homes in December. So the story so far has been very short. It's been very much from mid-December till now. And we've already got through those key priority groups. So we knew those all over the age of 50 needs to be a priority. The evidence so far says that anyone over the age of 50 is very much at higher risk of mortality and hospitalisation. So we began doing those priority groups. And we've done that priority group now. We're now on phase 2, as we're calling it, which is everybody under the age of 50 down to the age of 18 predominantly. And we anticipate that we will do that and complete that whole course of both first and second doses by mid-August. So between December and mid-August, we will have done the population, the adult population, 2 doses using 2 different types of vaccine. We continue to be, and as you alluded earlier, around the safety of the vaccines, there is, and I'm sure you all know this, but the UK have a guidance committee called the JCVI, and they are continuing to examine the evidence and review the data, as well as our medicines regulator. So we are following their policy advice. They are our biggest steer around the programme. Our other biggest steer has been vaccine supply, and one of the questions that we faced right at the beginning, and we still seem to face, is why aren't you doing this any faster? And when you see the numbers in the UK that they're doing millions each day, there is a constant question, can you not do this any quicker? And it's just to say that from the beginning of the programme, the only constraint that we put on ourselves was vaccine supply. So the limitation has always been vaccine supply, and we are based from the UK's vaccine supply. So we have an equal amount of vaccine based on our population. So it's called population proportionality. So us, like all the other nations, England, Scotland, Wales, and the other Crown dependencies, are given a proportion based on our population. And when you look at the UK data, we are vaccinating at a very equivocal rate to the UK. Wales are slightly above us at the moment, but Scotland and England are just slightly below us. But when you compare each week, we are definitely vaccinating at the same rate as the UK. And our only dependent, as I say, is that vaccine supply. And we've got staff ready if we had more vaccine. Next slide.
There we go. I think you're seeing it at the moment.
So as I mentioned, these statistics for today. Yeah, that's great. Thank you. Yeah, perfect. So as I mentioned, we publish our data twice a week. One of the challenges we faced at the beginning was we've never done such a widespread vaccination programme, and we need to make sure our data was very accurate. Once you start publishing it and putting that within the public realm, you need to be absolutely confident over the figures that you're publishing. And to do that whilst also setting up a programme was very complex. And so we initially published the data once a week. We only have, as I say, we have a small team. We have 1 person in informatics to support us. So it needs to be confident over the numbers that were provided. So we did that once a week, and we've now stepped that up to twice a week. But our data at the moment shows that we've done 88,000 doses, which is incredible. And 35,000 people in the population have been fully vaccinated which means they've had 2 doses. But we know that 52,000 out of 107,000 people, which includes children, have been vaccinated. So we've done really well in terms of the coverage at such speed. Next slide. Next slide, please. So it's really important we look at where we are in terms of the adults. So the over 18s, we've done 61% have received their first dose, and 41% have received their second dose. So we know that first dose gives you the biggest push. The second vaccine tops that up and hopefully will give you the longevity of the vaccine effectiveness. Next slide.
Have you got the next slide?
So as mentioned, yeah, thank you. So as mentioned, where are we? And this is really important, I'm sure, to the group listening, is where are we compared to others? We don't publish this because it really is not a race. It's a public health campaign, and we're trying not to be compared to other jurisdictions, but just for your relevance and for confidence and assurance, we are vaccinating at pace comparable to the UK. So overall, the vaccination per 100,000 is around 73, and we are at 82. So just below Wales, but above Scotland and England and Northern Ireland. Next slide. Again, another key question I'm sure for those listening is around how we are doing internationally. And the answer simply to that is we are well ahead internationally, and we are being incredibly lucky to be part of the UK vaccination programme. Again, one of the challenges and questions we received frequently at the beginning of the programme was, why could we not just go, if vaccine availability was our limiting factor, why could we not go and purchase that elsewhere? And I think that the answer to that is now very simple, that the UK have been very strongly positioned in their acquisition and purchasing of vaccines, and that has placed us very strongly internationally around our vaccination campaign. So as I say, 60% of all adults over 18 have now had their first dose, which when you compare internationally puts us very strongly. Next slide, please. So to the final slide, just to pose a few questions, the frequently asked questions, and I'm sure that you've got plenty of questions which I'm happy to take, but just as a starter, to perhaps start that conversation off, is one of the frequently asked questions we get is, can a person still spread COVID if they catch it and after they're fully vaccinated? So the prime endpoint of all the vaccination studies so far have been the effect of the COVID vaccination on your likelihood of ill health, death and hospitalisation. And the evidence around that is now very strong, that the vaccines are incredibly safe, and they also reduce the numbers of deaths, admissions to intensive care and illness. The evidence around transmission, most vaccines prevent transmission of illness or of the disease, but that hasn't been the research endpoint for most of the studies so far, but that is now becoming a big area of research, and the evidence that is now coming out is that it will potentially protect you from transmission too. It won't fully completely stop you getting COVID, and we know they are incredibly effective, but there is still a chance that you may contract a COVID. But if you do, the evidence is that you are less likely to be incredibly poorly if you do get the vaccine. So the second question is, will under 18s receive the vaccine, especially if they're considered high risk? One of the hot topics at the moment is we've done all those high risks at the adults, but we know there's a population under the age of 18 who have a high risk. So potentially, for example, children with CF, other groups. We've not offered the vaccination to children yet. The evidence and research studies are being done at the moment. There's 2 main studies being done in children, one on Pfizer and one on AstraZeneca. And we anticipate that the studies for Pfizer will be published and reviewed by the JCVI very shortly. But at the moment, children aren't being vaccinated, and our current cut-off rate is 16. but the majority of those are all over the age of 18 at the moment. And as I said, our policy position is to follow the JCVI advice, so we need to wait for that policy to be issued by them. Third question, if you don't have a reaction to the vaccine, does that mean the vaccine has not worked so well and your protection against COVID might be less than someone who's had a reaction? So it's a frequently asked question. We know that AstraZeneca, the first dose, some people have side effects more on the first dose than the second, and Pfizer, it's alternative, so most people get side effects on their second dose as opposed to their first dose. We know that having a side effect is generally a result of your immune system recognizing and kicking in, but it generally does not mean, though, that you've not had a reaction to the vaccine. And we know that the studies show that the vaccines do produce a good effectiveness in most people. So other plans for vaccine certifications? Well, I've put it in here. It's not my area of work at the moment. The modernisation and digital team are working at pace to produce the vaccine certification, and that's being done jointly with the policy team. So not an area of my work, but just to let you know that that is being considered and pursued through the government. So over to you.
Excellent. Thank you very much indeed for taking us through that. And we'll take that off the screen for the moment. And I just wanted to pick up on one or two of those points there that you were making. And one of them is about the reaction to a vaccine. As more and more people are getting this, we're hearing more and more cases of reactions, mild reactions, an aching arm, being tired. Are all the reactions to vaccines pretty similar? You're seeing a trend in these. I'm just wondering if Adrian can come in on this as well, and you know, just comment on the reaction to vaccines, because that is a worry for some people.
Yes, thanks, Murray. So it's not unusual. It's not uncommon to have a reaction to a vaccine. It can be localized around the injection site, where it can become red and sore and tender. And certainly that's quite common in both vaccines. The more systemic, so generally feeling unwell, tired, muscle aches, etc., it is a reflection of your immune system responding to the challenge, if you like. But again, we've not found that we've had anything really more significant than that in our patients. There's clearly evidence from around the world of risks which are well publicised. The risks are incredibly small and certainly are outweighed by the benefit of the vaccine. Probably around 20% of people will get some sort of reaction to the vaccine, but it will be mild. It will be a flu-like illness for 24 hours. It will be some muscle aching, some lethargy, occasionally an upset tummy. But it's not of any great significance. Obviously, it's uncomfortable to the person having the vaccine, but the benefit of having that vaccine far outweighs the short-term side effects that people have.
Thank you. It's still a question that comes up, and I know it touches back to where we started in terms of needing a vaccination. Is there a group of people that don't need a vaccination whatsoever? And if they don't need it, is there a benefit in them having a vaccination? Is there something in having the whole population vaccinated that makes a greater benefit for the entire population? I wonder.
So certainly in medicine, we talk about the risks and benefits of anything, really. You know, what's the risk from the disease, what's the risk from the vaccine, and what are the benefits from the disease, you know, or benefits from having the vaccine, more importantly. So it's clear there's absolutely no debate about the fact that over the age of 50, your risk of dying from the disease is much higher, several hundred times higher than the risk of dying from the vaccine, certainly. But we've got increasing evidence that younger people are developing long COVID, for example, which is a long-term viral-induced, viral-caused multi-system problem with heart, lung, kidney problems. And therefore, the benefit of protection is increasing in terms of the research that's being done. There's obviously been things in the press about clots, particularly clots on the brain, and more data is being collected by that, and it's an ever-shifting world, obviously, as more people are vaccinated. But again, you must put that into the context of something like 40 million doses having been delivered already. and the risks of having those problems being very, very, very small. The final point for the younger age group, which is those under the age of 50 and outside of our phase 1 vaccine program, is that actually there's a bit about protecting yourself, but also protecting everybody else. We know that if there is an unvaccinated population in a country, then the risk of new variants developing is significantly raised. So this is about a community where if we can get to enough of our population vaccinated, not only would it protect us, but it will also reduce significantly the risk of variants developing or getting a hold within that population. As Becky's already said, we've got increasing evidence that the vaccines give good protection against all of the variants that are currently out there. There's certainly technology going on to look at, do we need to change the vaccines and make them more responsive, just as we have done for years with the flu vaccine each autumn and winter. So in summary, I would say it's really important that we all get vaccinated. You know, they keep saying that no one's safe until everyone's safe. But it is very true for a vaccination program with a disease that, as we've seen in other parts of the world, is still a significant threat to everybody's health. Is that helpful?
It would be helpful if I unmuted myself, of course, which is inevitable, and someone has to do it on every call. It's the law now. In terms of questions that are coming in, I think it's quite important that we get through some of these as well. And we've had some of these questions before on previous ones, but I'm just going to run by some of these again. Just in terms of data, Adrian, you mentioned there the likelihood of death through COVID in older age groups is higher. Presumably there are stats on all of this, and there are stats that say, well, if you're in an older age group, you're more likely to, and we've got stats to prove that that has happened.
Yes, we have. We've got good statistics. So, for example, if you are above the age of 80 and living in a residential home, you're 700 times more likely to die from this disease than the normal average person. And in some nursing residential homes in Europe and in the UK, the death rate has been 13%. Now that to me is a terrifying disease. We have managed it incredibly well in both our public health measures, our vaccination and our healthcare system on the island for the waves that we've had so far. We had a particularly frightening one at Christmas with the suddenly increasing numbers. But we're learning all the time. So medicine is ever evolving, and in times of crisis, you learn things very quickly. So we've learned a lot about how to manage people in the intensive care unit and look after them better, how to manage the public in terms of social distancing, isolating, etc., how to manage the nursing and residential homes. GPs and colleagues from primary care have been amazing at continuing to provide care for those people and the general population as well. So the death rate is terrifying in the elderly. It does reduce, absolutely it reduces as you get younger, and certainly below the age of 50, your risks of death are significantly lowered. However, your risk of long COVID seems to be much higher than we previously thought, and that's an area that is being developed, as I've said. And also the public health thing about protecting the whole population is very important.
Thanks. Becky, going to come to you because you, not that you are, but just talking statos here with you and Ross, and we just saw some of the fantastic figures that you showed in terms of the detail of statistics you're collecting. Presumably there are stats available in terms of how many people have had which one of the two vaccines, whether AstraZeneca or whether the Pfizer vaccination, which are the two available in Jersey. So you've got those numbers, you know how many have had each. Do people have a mix of, can they have an AstraZeneca and then a Pfizer? Is that possible? Or if you have your first AstraZeneca, do you have to have a second AZ vaccination?
So the recommendation is that you continue to have your second dose as your first dose. So that's the current recommendation. It's not unsafe to have an alternative dose, but at the moment the recommendation is you complete your course with your first dose. So the recommendation, if you had AstraZeneca, you have your second dose and vice versa. We have followed the JCVI advice to where it's difficult. So, for example, we were using Pfizer. Pfizer was the only first approved vaccination that we were using initially. So we had to use that in the nursing and residential homes. Some areas in the UK didn't do that because of the logistics to do that. But we found we were able to do that because we thought that was so important to do. Going forward, that makes it very hard though. You have 10 doses in every vial. So if you, as you've done the most of the people in nursing and residential homes, as you go around doing them, one dose, you then have to waste 9 doses in a particular home, for example, because you can't take, if you constituted the vaccine, you can't then take it out of the nursing home. So we changed the policy position that we would be using AstraZeneca in the community, and we've been doing that. So there's a few people that have had initially Pfizer and then had AstraZeneca as their second dose. But generally, as a rule, it should be that you continue with your second dose.
Okay. Thank you. Plenty of questions coming in, and if you've got a question, then the Q&A box is where you put it to find out. And I want to talk about the next stages, if you like, of vaccination, if we're able to talk about that, because obviously you're now targeting those up to the age of 18 in the between now and August. So that's a logistics that we need to play out yet. But just in terms of the data of those, and there are lots of questions around it, people wanting lots of data, and I think people who will be either for or against a vaccination will be very keen to find out what's the data available for the likelihood of death through COVID in older age groups. Is this data likely to be available on gov.je? What's the data on COVID across the cohorts of non-vaccinated, AstraZeneca vaccinated and Pfizer? Are we able to put that up and go, look, this group of people here didn't have the vaccination and here's the danger. These people did have the vaccination and here's how much better or how much worse they are by having it. So I just wonder if that information is available. Presumably you've got numbers somewhere. It's just a case of producing them.
But the only risk that we are a small jurisdiction. So when you're looking at something around efficacy or the drug effectiveness, you need big numbers. So it's really important that we don't get enticed into looking at small numbers, because the confidence interval on those statistics then becomes a lot weaker. It's really important that your confidence interval and your reliance on the statistics needs to be bigger numbers.
Yeah.
So there are lots of international studies being done on risk, on effectiveness. So rather than trying to do small number studies here, it's really important that we look at the bigger numbers and the bigger studies that are being published in the UK. So which is why we publish what we're doing and how that's being rolled out, as opposed to the effectiveness on a small island at the moment.
Excellent.
Does that answer your question? Was that the question, or this point? Adrian, do you want to add to that?
Yeah, no, I was just going to reiterate that, you know, we've had over 40 million doses of the vaccine delivered across certainly Europe, and 100,000 people in that is a very, very, very small number. So we need to be really cautious about, you know, our island effect, if you like, compared to the large numbers that have been done elsewhere. That's really why we follow JCVI, because they have access to that data of tens of millions of doses and can look for any small changes, any small differences. I work in A&E when I'm not doing this work, and so it's just important to recognise that we've not had an admission from a nursing and residential home due to COVID for I think 2 months now, and we are at 30 days since we've had any community outbreak of COVID. So whilst that's not hard data, in a small community that has a big impact. So I think it's important to put our local community into it. Of course they are. There's lots of evidence, lots of papers. If people go onto the JCVI and the MHRA websites, there's lots of analysis across several countries involving tens of millions of cases, which will give you much clearer mortality rates per age group.
Thank you, and thanks very much for filling in that gap. I wanted to pick up also on long COVID, Adrian. You mentioned that earlier on. And I just wanted to just unpack long COVID as opposed to COVID. What is long COVID, firstly, and what are the age ranges that we're seeing of that, and are we seeing any of that in Jersey?
Sure. So I think there are good definitions of long COVID. Predominantly, it's a disease that has lasted with symptoms beyond 30 days and has affected more than one physiological system. So a virus, when it gets into you, goes everywhere. It goes into your brain, it goes into your spinal cord, it goes into your heart, your lungs, your kidneys, your liver, your bowel, your skin, and then manifests itself in all sorts of different ways. So that could be a rash that lasts for weeks and weeks. But the more worrying versions are the ones where it's caused significant irritation, inflammation of the brain, inflammation and irritation of the heart, the lungs, the kidneys. And these are a growing number of people, clearly, since the disease is now gone around the world and is going around in several waves. We are going to get people with that. It's no different from any other viral infection that people have had, except that the numbers are more. So in terms of the age groups, it seems to be at the moment a disease that's affecting younger people, so not necessarily children. In fact, there's not a significant incidence in children under the age of 9. But as you get into the 20s, 30s and 40s, there seems to be a group of patients who are developing these long COVID symptoms and can be really difficult and a real challenge for doctors to manage because it's multi-system and it's long-term health problems. It's an area that we're getting more information about. It is still in its early stages. We are starting to look at potential long COVID on the island to see if we have cases like that and how we're going to manage them, because it's a disease that needs multi-specialty input. It's not just seeing one doctor, it's seeing somebody who can monitor the heart, the lungs, the kidneys, etc. So we are learning about that at the moment, but it is a concern for people. How bad it is yet to be quantified. How frequent is it? Again, we're a small island, you know, we need to start collecting that information, which we're doing. And then we need to have a system whereby we can manage these quite complex medical problems for the patients.
Okay, thank you for that. I'm going to move up to Ross and Becky on the next point, which is related to younger people and long COVID. Presumably getting, and again, this is on the assumption of the vaccinations and the effectiveness of the vaccinations. Moving to a younger age group, does that provide you with any different challenges to that you've done already in terms of the logistics and getting this vaccination done?
I've never known a program that has changed every single week, and as I said, challenge every single week. So to say that I don't think it's going to be a challenge would be complete made up. I wished it wasn't. It would be lovely to have a few weeks where nothing changed, but there are unique challenges for whatever population group you're doing, whether that's a nursing home, whether it's 80-year-old, whether it's in the 70-year-olds. Each of those have required a different communication strategy. And we are incredibly lucky to have Sarah as our comms lead. She's been incredibly supportive and very innovative in how we've done that. As we move to those who are in the younger age groups, we're going to be using TikTok and all the other social media channels, which I haven't a clue about, and Sarah is going to be leading on that. So we're going to be using different communication strategies for all those under the age of 50. We've used a Facebook Live for those above the age of 40, but my understanding is Facebook isn't used by those under the age of 40. So Sarah's leading on all of those sort of comms. We do anticipate we will get good uptake. The evidence so far is we should anticipate to get 80% in each of those population groups. So we've never done this before, so until we've done it, until we've tested it, we don't know what the uptake will be, but we'll be working hard to try to get those groups. Do you want to talk about logistics in any way?
Yeah, so as Becky said, it's certainly a big communications challenge to try and talk to those different demographics in different ways, but we've got good plans in order to put that forward. And what the challenge is for me on the operational side is how to offer the vaccine as quick as possible whilst whilst it's still very, very topical, people still understand it. You see the restrictions when you leave your home and you go about your business. And clearly, the further we get into the future and the disease starts to wane, as we're in the fortunate position as we are right now, obviously people's interest will go elsewhere. So we're working with the UK to give them our supply and logistics challenges, and they're helping us through that and getting us as much vaccine as they can as soon as they can, and so that we can press on and keep the momentum in the programme. But I'm certainly confident over the next month, and we'll be making an announcement later on today about some next cohorts, that we'll be able to keep that momentum and keep the interest peaked. And certainly from what you'd have heard from Dr. Noon and Becky today, is that everyone should have it, and you should do your very best to get your appointment when you're offered it. And if people do have more questions, or they're not sure, or they think, oh well, I'm young, I'm fine, I'll get over it, then have an appointment anyway, because at least you can come up here, you can speak with a vaccinator, you can have a medical screening, and talk it through with a professional, which might just be the click that you need. And even if after that your mind's not changed, at least you're here and you can have it. It's free of charge, and you're better off for having it. So I'd certainly encourage everyone as we move through the next demographics to come up and get their vaccine as soon as they can.
I don't want to throw aspersions on a younger cohort, but there are people that think they're indestructible, and actually at my age I don't feel indestructible anymore, but at 20 I probably felt I was. So I just wonder if there is that mentality of wanting to do that, and I suspect that's going to come into the comms side of this. But I just wondered if there is a different messaging and a different way of being able to say vaccination to those in the 20 to 30 age group, for instance.
And it's more about getting back to the normal, isn't it? Oh, sorry, Adrian, go on.
No, I think we all feel like we're invincible when we're 20, don't we?
Yeah.
But it is, as Becky, I'm sure, was about to say, it's about trying to get our society back to as near normal as we can as quickly as possible. Certainly the younger people have suffered tremendously in terms of mental health problems during COVID, and the isolation and the change in their work, their access to their normal social circles, their access to their sporting facilities, their leisure time, etc. All the things that we all had and took for granted when we were younger. And I think the important messaging about this is that the vaccine will help us all to get back to that position as quickly as possible.
Thank you. The gap between your first and second, because there's still a large group that have had the first that haven't had the second yet, and obviously that's going to be happening. Am I right in thinking it's the 12-week gap that's between? I've seen that vary from country to country. What's the thinking in the gap between the two? Is it good to go as long as possible, or is it better to have a shorter term between vaccinations 1 and 2?
Yeah. Shall I start with medical?
Adrian, do you want to do this one?
Yeah, and then Becky, you can add in, and Ross, you can talk about the logistics, I guess. Vaccines have to be licensed, and to get their license, they have to have gone through a very rigorous process. Initially, they were trying to get the vaccines licensed and out as quickly as possible. So the shortest period of 21 to 28 days, which was the Astra and the Pfizer vaccines, were done so that they could collect the data very quickly. From an immunisation point of view, the further you can separate the two vaccines, the longer your effect. So we've seen it with tetanus vaccine, for example, which most people know. You have a course when you're young, and then you have it every 10 years, and that's meant to give you longevity of cover. Hepatitis A is another good one, where when we first started giving hepatitis A vaccines, they were 4 weeks apart, and now we recommend 12 to 18 months. So it's a delicate balance between getting cover from the disease and trying to give you longevity of immunisations. We have always said that we can vaccinate up to 12 weeks apart. We haven't got strong, robust evidence as yet, but certainly indications are that the further you leave those two vaccines apart, the better the longevity of cover. Obviously, the vaccines have only been out in huge numbers over the past 6 months, so we haven't got great detail on that yet. but common sense would say that if you can mount an immune response and then stimulate that response a longer period away from it, then it will give you length of memory T cells. So I guess the medical answer is that the 21 to 28 days was initially for licensing and thought that that would get it out as quickly as possible. There was then obviously the desire to get a first dose given to as many people as possible, since that was the big jump from 0 cover to 80 to 90%. As we're developing things and learning more about the vaccine and its ability to generate antibodies, then as long a period of time between the two will probably give you better length of immunity. That's the sort of medical speak. I think Ross can certainly talk about the operational targets that we set ourselves and how we've delivered those.
Yeah, I just wondered on the operational.
Sure.
Thank you, Ross. With you, Ross.
Great. Yeah. So good. So as Adrian said there, we have our parameters set by the manufacturer and also the MHRA and the JCVI in the UK of when we should be aiming to give everyone a second dose, which at the minute is between the 4 and 12 week mark. So certainly no later than 12 weeks, but no sooner than the 4 weeks. So how we do that from an operational perspective is we look to balance the supply we have along with which demographics we're vaccinating at the time, and what that means effectively on a calendar of how many vaccines do we have, how many can we administer, and therefore how quickly can we proceed through the different priority groups. Now clearly back in December, January, February, supply chain was much slower as the manufacturers got up to speed with manufacturing all these millions of vials of vaccine. That's getting better every day, and manufacturers are increasing output, and therefore our supply is increasing. So we had a relative period early on in the programme where our demographics and the ability to move on to the next priority groups was fairly stretched out because of the supply we had. We were only able to offer a low number of doses that we could administer each day. Clearly, that's now caught up, so we're able to vaccinate a lot quicker. But we're also, for those demographics, approaching the 12-week point. So we've needed to make that switch from first doses to predominantly second doses, which is the sort of period we're in now and starting to come towards the end of. And then we switch focus back to the first doses for phase 2, which is the ongoing age groups from now. So it's all about trying to achieve balance and use the vaccine we've got as soon as we've got it, because we don't want it sat in the fridge or in the freezer not being used. We want it in people's arms. We also want to, as I mentioned before, keep the momentum in the programme by opening to the next priority groups. But we've always got to keep our eye slightly over our shoulder and looking at who we vaccinated already, and make sure that we vaccinate them in an efficient manner for their second dose, and certainly before the 12-week point, which in the vast majority of cases we're able to manage that and to pull people through. And looking at our statistics, over 99% of our second doses are administered between that 4 and 12-week point. So we're able to pull people through and give them their full protection while still maintaining that momentum of moving forward to those who have had nothing yet, and opening to those new priority groups.
Excellent. Thank you for that. Good full answer. We like that. I'm going to go to another one of the topics here, which is around, if you like, moving away from the distance between the two jabs and talking about some talk that's been in the media regarding COVID booster shots. I suppose that must be the next step that we start looking at. Okay, you've had jab 1, you've had jab 2. Is there a point after that where we look at boosters? So where are we on that? And what's the general thinking on boosters? Well, we're coming back to Dr. Adrian, I think, for this to start with. Booster jabs, where are we?
Thanks, Murray. So I would think June, July time, there should be some evidence about what we should be doing in terms of the autumn and winter. So clearly we have a vaccination program that runs every autumn and winter, which has run for 25 years. And there's going to be some discussions about, we've got to deliver that and potentially a COVID booster. So We haven't got the evidence from JCVI yet about it, but the likelihood is that there would be a booster offered to people over the age of 50 or the immunosuppressed or people at maximum risk or healthcare workers would make common sense once we know how effective the course has been that people have already had, whether it is going to last or whether it's going to be benefit to give an additional vaccine, whether it's one of the current ones we use or whether there's new vaccines that are brought out. As we all read in the papers, Pfizer and AstraZeneca are looking at modifying their vaccines to pick up potential variants. Again, as we do every year with the flu vaccine, we look at the previous year's types of viruses that have caused that vaccine and try to develop a vaccine against those and change it every year. The difficulty is that it's obviously been compressed in the timeline. So whilst there's no formal announcement, I don't think you need a degree in medicine to work out the fact that almost certainly there will be a booster program at some point to keep the population protected from any potential variants that may come along. Becky, would you like to add to that?
Yeah, I love your analogy. You don't need a degree in medicine to work this answer out. But yeah, the evidence, as Adrian said, is the kind of three key questions is how, where and when. And we need the information from the UK about that. So when are they going to recommend that we give it? Is it in the autumn or is it going to be later on in the year? What do we need to give? So the potential could be that you get the same type of vaccine or you get an alternative vaccine to the one you originally received. And also, who do we give it to? So they're key bits of planning that we need to have that information from, and that will come from the JCVI as a recommendation. And then with those bits of information, we can then scenario plan to deliver that on Ireland. But I'm an observer on the JCVI. We've got good links with Public Health England as well as the Department of Health and Social Care. So they're working really closely with us to make sure that we're part of their scenario planning again, as we have been so far.
Ross, I just wonder from the operational side, and Becky, this is for you as well, does there come a point in August where you go, that's it, we can close down this vaccination program of its enormity that we have now, and everyone, when and if they end up doing and you go back to your normal jobs, whatever they were, and so I just wonder if there's a point where the vaccination program ends and we have an end date in sight, which is, you're saying August, and then people are going to be able to go to their doctor or to their to a medical centre and be able to get the booster if that's what it's going to be. Is that how you see it playing out?
I think there's a number of different scenarios in which it can play out, and as Becky said, the JCVI are working through those scenarios and who may be eligible for what and when. So certainly what we're providing now is a mass vaccination program, and we really need to focus on that. It's not a personal service because we need to get it out at mass into the population, but that won't always be the case. And yes, we will reach a stage where it will no longer be efficient to administer first doses and then second doses in the mass vaccination program that we have. So we are looking at ways in how people do access their vaccine if they haven't had it by that point, because again, we focus on boosters, but there will be people out there who haven't had their first dose yet because they're not sure, or they're waiting because they have no dire need of it right now, in their opinion, and that situation may change on a personal level. So the vaccine needs to continue to be offered, whether it's through this program or not. So we're certainly looking at those options of how this vaccine is offered in the future on an individual level. The booster program is slightly aside to that. Again, if it's depending on what the JCVI recommends. If it is a do everyone again, then again we'll consider whether that is a personal service for people doing their own time, or whether it is efficient to extend or reinvigorate this program when the time is right. But there are a lot of different scenarios on the table, and until we've got that guidance and considerations and assumptions from the medical experts in the UK, and then can be considered by our own medical experts and government officials, politicians here. We really won't know how that's delivered until later on in the year. Okay,
thank you for that. A couple of questions about not having the vaccine now, but then wanting a booster in the winter. I suspect this goes back to a medical question, but I'll open it up to all of you. If you don't have jab 1, jab 2, and then this winter go, actually, I think I need a booster, would that be the shortcut, or do you not know yet if that's possible? Or would you have to have the first 2 and then have boosters?
Again, it's unknown, Murray, at the moment. We know that the first dose of a vaccine, pretty well all the vaccines, gives very good protection, variable, but somewhere between 70 and 90% protection of the current variants that we have out there. Yeah. So I think if you don't have your vaccine course now and then you suddenly change your mind in the winter, then there would be advice as to whether you need to have 2 doses or just 1 dose when it comes round to that.
Okay, good. I'm going to rattle through the last couple here. Vitamin D capsules being given to some residents along with vaccination. Is that something that Jersey's thought of, considered, decided not to do?
There wasn't part of my other role is to look at what medical therapies are of benefit. We know that dexamethasone, which is a steroid, is significantly improves outcome for people admitted to intensive care units, reduces their mortality by 25% and reduces their multi-system failure significantly. Others, we've not got such strong evidence. When this first started, there was lots of thoughts about vitamin D, absolutely, and there was some evidence to show that it was of benefit. Again, I think in the times of desperation, you take anything to try and reduce your risk of getting the disease. I think if you're going to think like that, then the one thing you should do is get yourself vaccinated.
Right, fine, okay. So the supplement, vitamin D, perhaps a little bit of sunshine might not be a bad idea, but we'll
be excellent for us all, wouldn't it?
Yeah, we'd all like a little bit more, wouldn't we? All right. One final question here that was up the list of questions and we haven't been able to tackle yet. Someone says, I heard recently of someone there being reported, a few women reportedly changes to their menstrual cycle, increased regularity in that, in fact, following vaccinations. Also mentions of being affected just by being in the proximity of those who have been vaccinated in terms of menstrual cycles. And I just wonder if you've heard anything on this, if there is any advice on this.
There's no evidence that it affects women's menstrual cycle, and it is having increasing evidence of safety in pregnancy. So I've not heard of anything about that.
Yep. Okay. All right. Well, sorry, Becky, coming to you.
Shall I add in? Yeah. So if people have concerns around side effects or want to report those, there is a mechanism to do that. So we would encourage people to fill in the yellow card system. So if they've got a concern about potential side effect that they are attributing to any medicine, but you can do that through the MHRA, through the yellow card system, and that can be done through a healthcare professional or as an individual too. So you can do that through the yellow card system. That then the MHRA then look at the safety signals. So if people report in huge numbers or there are an increased incidence, they can examine that as part of the safety mechanism. So it's something that the MHRA look at in all safety instances. So yellow card, we recommend that people want to report through that.
Grand. I think we've come to the end of the questions. There was one about if we're UK and Jersey residents are being vaccinated in such high proportions, is the current level of risk low enough to consider less stringent policy for travel? I know that's outside of your remit, but I'm sure that with your knowledge of what you're doing, you feed into that greater conversation. Would that be fair to say?
Yeah, so I sit on STAC and we advise the government on all sorts of areas. And there is work being done at the moment to look at the travel policy, and I think there will be announcements shortly. It would make logical sense. We all need to try and get our lives back on some sort of track and see our loved ones back in the UK. You know, I think we've all got stories, haven't we, my mum lives in a residential home in the UK, and I haven't seen her for 18 months. I'd be desperate to get back and see her, but we've got to be proportional. We've got to be safe.
Yeah, well, I'll concur on that one. With a mid-80s father who's been suffering from Parkinson's for 10 years, I'm really keen to get and see him as well. So I'm just as keen as everybody else. We all are. Becky, you wanted to come in on that?
Yeah, it's just that whilst we're in a very privileged position, we have high rates of vaccination, very low levels. This isn't a disease that's gone away, and there is still the threat of a third wave. So whilst we live in quite a nice, comfortable position at the moment, we still need to be really careful that actually a third wave is a real possibility. That ending on a doom tip.
No, well, I was gonna not end on a doom tip actually, and just come back to you, Adrian, just to say that given the fact that we now observe better social distancing than we've ever done, and probably will continue, that we have greater knowledge, whilst we already knew it, about cleanliness, space, mask wearing, washing our hands. You know, I hear lots of, I don't know if they're mythical or not, stories about people saying, well, the occurrence of flu this year has dropped through the floor. Is that because our hygiene habits are much better, and are we all going to be a lot better with our hygiene now?
So it's true, we've not had a single admission with flu through the winter into hospital, and the cases in the community have been exceptionally low. And it's good and bad news, I'm afraid. So the good news is undoubtedly that's due to these NPIs, the non-pharmaceutical interventions. So that's social distancing, mask wearing, washing our hands is the most important thing, and being sensible about how we behave. Clearly, we wouldn't want to do that every winter to just say that we've had no flu. And also there's an increased risk that we now have a population that didn't have any flu this year and potentially could be more exposed next winter to flu when it's around, which is the doom and gloom bit of it. But yes, there's certainly something we should be learning in the longer term. We can argue about mask wearing and whether that should be used or not, but certainly washing our hands regularly is a very simple thing to do, and will remarkably reduce transmission of this virus.
Final question is on masks, and I was asked. I am unmuted now. Final question is on masks. When are we going to see the masks? We're seeing it already because it's guidelines, people are using masks less than they were. I think that's a general acceptance that the occurrence of mask wearing is starting to fall away, particularly in open areas. I just wonder what we're going to do with schools and what we're doing with people in workplace, and whether we're going to see less mask wearing, and there'll come a point that we can say, it's okay, you don't have to wear one now.
Yeah, I mean, I have to wear a mask for 8 hours every day, and I'm not allowed to touch my face. And in the height of the epidemic, I was wearing a respirator for 8 hours a day without having to touch my face, and it's not pleasant. Nobody wants to do that, but again, it is well evidenced, despite what people might say on some social media platforms, to reduce the spread and the risk to others. Again, I think we are in a much better position than we have been. I think we've got the summer coming. I think our rates are dropping, our vaccination rates are going up. It was reviewed at STAC last Monday, and advice given to policymakers, and I'm sure that they will look at that advice and act accordingly. But come back to Becky's point that we are not quite there yet. We've got another couple of months, I suspect, before we've got 70 to 80% of our population vaccinated against the disease, and we still have a significant risk of variants getting into the population, and a proportion of the population that aren't vaccinated. So I would say we're not quite there yet, and it's very tempting to just say let's be done with it and get on with our lives. There would be nobody happier to do that than Becky, Ross and myself, but we have to keep our population safe and protected until we've got to that position.
All of you, thank you very much indeed for doing what you do and also giving us the time that you give us as well. We've run out of time for questions. I haven't got time for the last one that's just coming in, but I thank you very much indeed. And for anyone watching this or knows someone that should be watching this, then we will be providing a link with Chamber and through government for people to be able to watch it back on YouTube at a later time. Adrian, Ross, Becky, thank you very much indeed for your time as well. And Sarah, I know, has been arranging everything in the background. We appreciate all of your time as well. And we'll see you on the next web chat. Until then, thank you very much for joining us.
Thank you, Murray.
Thank you.
Thank you.
Thank you.